name's Tom Loker, and welcome to the HealthReform 2.0 podcast. This is our inaugural episode. This is our first episode. We're going to kind of talk through a few things today, but our podcast is really for people with a curious mind who would like to find a way to get a better healthcare system in America. That's what this series is about. And I will be joined on most of these shows by a very good friend of mine and a partner in this venture, Tim Henning. So, hi, Tim. How are you?
I'm good, buddy. How you doing today?
I'm doing pretty good. I'm glad to have you on the show. And, you know, you're really the guy that is going to be driving our agenda. So what are we talking about today?
Well, thanks, Tom. It's a pleasure to be here. And I hope people enjoy this podcast. It's very near and dear to our hearts, as we've known. You and I have been doing this for a very long time. I've been involved in healthcare my entire life. I think you have too. We're doing this to help enlighten, educate, kind of give people a grounding of where we came from and how we got here, and some of the things that are facing us as the most important part of the healthcare program, and that's the individual patient. So I think this is going to be inspiring. I think we're going to use the work you've done extensively in this area to help people understand, more about what's going on and break down some of the myths, and also give them a grounding in really what has happened and how we've gotten where we've gotten and what we need to do collectively to improve and make healthcare what it should be for all Americans.
Well, where do you want to start? How do you want to organize the shows? How are we going to carry this thing forward? Where are we going to start our story?
So I think the first thing we need to do is give our audience a little background of who we are, kind of where we're going with this, what the goals and objectives are, and where we are today in our particular healthcare quagmire, which we're going to get into here in a few minutes. As I use that term very directly, because that's what we're in, is a quagmire. But let's start with a little bit on you. I've known you for 10 years. It's interesting how we met. I won't bore everybody with that, but we've worked on many different programs, from women's health to robotics to just overall healthcare reform. I know you have a tremendous background. You wrote the book, The History of Healthcare and History and Evolution of Healthcare in America, which I've read 3 times and still trying to figure everything out, but we're going to help the audience with that this next series of episodes. Your experience on Capitol Hill is extremely powerful and should give people a great deal of knowledge of what happens there and what's going on. Your experience as a healthcare provider over the course of the last number of years, I think should give them some great grounding of where we are. And I think, given that background, you bring a tremendous amount of knowledge and background that people may not understand. I've been in the healthcare business for quite some time, mostly on the provider side. And one of the things that we want to do is take all that collective knowledge. If you add it together, it's 75 years, which we're dating ourselves for sure, of collective wisdom.
Wait a minute. All my gray hair comes out of a bottle. I don't know about yours.
No, mine's real. Mine's real. And I just turned 65 this year. So I started in this business when I had diapers on. My father was director of a department in a hospital. And I've lived this thing from the beginning of time.
So you had a crappy job when you first started, and you have had a crappy job many times in your career, I'm sure.
Yeah, the whole healthcare thing has been interesting for me, the transition, because there was a go-go year. I mean, we're going to get into that in the history. This is where you couldn't print money fast enough. You could make money hand over fist in this business, which is one of the reasons why we're in the situation we are today. So I've seen it everything from complete chaos to now what we have is total mayhem along the way. Both from the provider, from being on the OEM side, providing technology in this environment, and unfortunately also on the consumption side, where I've experienced some very negative things. I had a daughter die of leukemia. I've seen the healthcare situation from all extremes, from the very, very best to the mediocre to the absolute most horrible situation that you can imagine. And not only have I seen it in the United States, and you have too, I was fortunate to spend a great deal of time in Europe, running some healthcare programs in Canada, in Latin America, and in Asia. So we've seen it from multiple different perspectives, and I think we get myopic as a healthcare consumer in the United States, not seeing the true picture of what's going on globally. And there's a lot of myths associated with this, and I know we're going to get into that a little bit later in the podcast.
Well, it's you're right about that, and your background has been, like mine, varied. You've seen it from a number of different angles. I was fortunate enough at one point in my career to be working at Packard Hospital and focusing kind of on the business side of the hospital at the beginning of HMOs, and I started looking at how pricing and things were changing and how it was affecting practice, and got a real shock at the earliest points of billing that was going on in the system, and recognizing that if we kept doing it that way, we were going to have a real problem, a real break between what it looked like we were trying to charge for a good and service at Packard, as an example, or almost any hospital, and actually what we really expected to get paid. And it became very, very divergent. It created a false economic structure that we suffer with today. And frankly, it is core to kind of the problem that we have, the quagmire and the large myths that we have today. So what would you like to talk about first as we enter into this thing?
So I think the first thing we want to do is tell our audience what our sources are, because I think that's important for them to understand. So there's a number of sources we're going to use in this podcast. One, of course, is your hit book, The History and Evolution of Healthcare in America. That's going to be the grounding of our history lesson on how we've come from where we've come and where we got to today. The second is a great book written by Mayer, and the name of that book is Money Driven Medicine. It's an excellent book. Overdiagnosed by Dr. Welsh. There's a number of other books that we're going to be using and referencing along the way. So I just want our audience to know that we look at a broad scope of different sources that we're going to draw our information from and our stories from. But a lot of it has to do with what we've experienced. With all those years of being in this particular environment, all the people we've interviewed, you working with Ben Carson on his campaign, my work with Senator Grassley, we've seen it from multiple angles. And, I think that what I want to inform our audiences is that, this is not just a conversation driven off of one particular source. It's multiple sources and multiple years of experience in this industry. So I'd like to go over what our goals and objectives are. Our goals are to inform our audience in a way that's more of a dialogue than I don't want to go death by PowerPoint, and a fun learning experience. We want to make it fun. There's going to be some jokes. There's going to be some things that I think are going to be really entertaining for people, especially when we get to the patent medicine part of the program, and when the things that people are just not going to understand, where we got and how we got there, and the fact that Coca-Cola had cocaine in it until 1903.
And many of these patent medicines still exist today too. They still do. They're just not medicines anymore.
So that's a whole segment I find the audience is going to find extremely interesting. Plus some of the politics that were involved. It's all politics, and a lot of it's driven off public policy, which we see today in what's going on in our environment and how we ended up here. And then I thought, once we got through the history, which I believe we can do that in probably 18, 19 episodes, we'll get to some of the ideas of how we can resolve this current situation. And so that's kind of the viewpoint I had. What I'd like to do is get through this particular episode as our kickoff episode, is getting a summary of where we are today. Before we launch into the history, let's kind of frame up where we are today and the particular aspect of the delivery of medicine. And the first thing I'd like to start with is the misconception of the word healthcare system. The definition of the word system in multiple meanings is you actually have a coordinated, logical progression of events and ideas and programs that drive a systematic process. We're anything but that. There is no healthcare system. I'd like you to expand on that because I want people to understand that. We use it, it's a throwaway line. I see it on public TV, I see it on the talking media. There is no healthcare system. So I'd like to start there and get your thoughts on that.
Well, you're right. And it's one of the core problems of what we have. It's probably the core problem, and it leads us into a series of other issues. But the first problem is if we look at what we call a healthcare system, I've just pulled up the slide, and I have the first segment of the slide up on the screen. If you look at this, you'll see that from today's view, this slide that was created during the healthcare reform days to try to illustrate the existing healthcare system, it is not in any way, shape, or form a system. In fact, a first-year system engineer in college would never even begin to think of this as a system. Systems are developed in orderly layers that communicate between the layers with defined roles and objectives. They are not put together where everything kind of moves all around at will and things talk to one thing and bounce back again. It's just not in any way, shape, or form a system. But if we take a look at this mess that is in this chart on the screen, I can start by saying we can start to think about a system by identifying the basic four legs of the entities that we need in any healthcare system we have. Well, obviously, the first thing we need is what we used to call a patient. And if a system is coming together, we would prefer to now call these participants because they're people who are seeking care that they need and they want to be able to get access to the care they want. And we believe that a participant shouldn't have to be patient to get care. Well, I've had people, and you've had people say to us, look, not everybody can participate in care. They don't quite always know what they need to do. They don't always know how to communicate well or don't understand what they're told. So the next leg of the healthcare system that we need to have are called facilitators. Well, we actually do have facilitators in the system today, but they're not accounted for in the system. They're actually excluded. They include, people like social workers and caseworkers. But in this case, facilitators should include faith-based people, social workers, caseworkers, family and friends, people that have guardianships. A parole and a probation officer, oddly enough, is also a kind of a facilitator of care for a parolee. Volunteers, public service people, other kind of people. Anyone that's going to help somebody find care, find their way around care, find a way to pay for care is a facilitator. And they can be family and friends as volunteers, or they can be paid facilitators, people that actually get paid to people who get help, like caseworkers or parole and probation officers. Well, obviously, the next leg of the stool is the people that actually provide the care. And that includes people like physicians and doctors and nurses today, but it should also expand to include in this virtual group of people helping an individual patient find their way around and get the care they need. It should include the pharmacist and a therapist and representative subspecialties and other kinds of non-traditional healthcare people that also help people move through the healthcare system and get the care they need and want. And of course, last is what we used to call payers, we now call sponsors, which are people that are paying the bill, either in whole or in part. And as we're moving further and further along, there's going to be less and less of an occasion where all the care we need is going to be paid by our insurer or by Medicare or Medicaid or even combinations thereof. We're going to find as we move forward, if we're going to afford care, we're going to have to be able to manage multiple ways to get payment to a provider for the services they give through all the various means that an individual may be eligible for. And most importantly, it's to coordinate that care. You have to be able to fully coordinate care and benefits across all four legs of the stool, all the available sources. And if you don't do that, you end up exactly where we are today, which is our current system is a quagmire. And we believe that if we start to go through this process, that we can put together a system where we can deliver order in this chaos, understand why it's chaos, and start to answer some of the questions, and then develop an effective healthcare.
So let me jump in here. So I think that uh, all those things that you described are absolutely true, but it kind of gets us to where we're going to go once we get through where we've been, for people to understand what some of the ramifications are and what some of the solutions are. I'd like to step back for a minute and get more into where we are today relative to some of the things that are facing people that they may not understand. Uh, we have the quagmire, which it, to most people, if you've got the routine type of stuff, you don't ever see most of it. You go in, you get your blood pressure checked, whatever. It's not until you have an adverse situation that you're in a situation where you're kind of lost. And we can go into that a little bit. I've been all over the world. I've been in healthcare throughout most continents, except for Africa and Australia, but I know the Australian system very well. Let's go back, I think, for a minute and talk about some of the myths. When I hear talking heads on TV, and I won't name them by name, but one of them is, you're my most unfavorite hosts on a certain channel, is they blow things out of proportion. I'm tired of hearing that U.S. has got the best healthcare system in the world. We can argue it one way or the other. That's not what the data says. The data says basically we're number 17 if you look on a per capita basis. But we can go into that in a whole new episode, which we will. Now, I've been in Europe. I've seen the good. I've seen some excellent care. I've been in Canada. There aren't people dying on the streets. I'll guarantee you that. As much as we like to think there are, or led to believe there are. I've been in Latin America. I've been in Sao Paulo. I've seen some tremendous amount of healthcare. And I've been in Mexico a lot. And I will tell you that people are totally misinformed, in my opinion, of what really is going on out there. So I'd like to sit back and go through some of the myths that really have plagued us and plagued our messaging and our media environment as to what our healthcare program here in the United States. I tend not to use the word system because it's not, but what's going on within the healthcare in the United States, and why are these myths so misinterpreted? Do you want to go? Could you step back that for a minute and see what you think about that?
Sure. Well, first is, let me pull up a quote from John Kennedy. And it was John Kennedy who said, "The great enemy of the truth is very often not the lie, which is a deliberate, contrived, and dishonest statement, but it's a myth, which is persistent, pervasive, and unrealistic. And it's the belief in myths that allows the comfort of opinion without the discomfort of thought. And to a great extent, many of the talking heads on television are propagating myths because they don't really understand the underlying problem in the first place. And as a result of that, this propagation of myths has been both accidental and also purposeful in the history of care. And I won't go into that because we're definitely going to talk about that in the near future. But many of the things that we think about healthcare today are just not true.
And that's I think people need to understand that, because it's one of the things I've found in my career is that we have a informed public, educated public, and we're seeing more and more information made available. The internet has done that. Also has a reverse effect where you get misinformation or you interpret the information incorrectly. The first thing a doctor will tell you is don't read the internet. However, I think people are more informed. I've seen more of that in my career. In running radiation oncology centers, I have people come to me asking me for photon therapy, not knowing the difference, CyberKnife, the different things that go into what is done in a radiation oncology center that you'd have to do some digging on to understand. And then you have a certain segment of the population that pretty much trust everything that the doctor says and doesn't question anything, which is completely alien to my thought process. And then the other people just don't care. So I think if you look back to what we have, what are some top things that I think that we need to make clear to the audience about what these myths are and why they aren't, what the plague is around these myths?
I mean, the first myth is we have a healthcare system, and we've already talked about that. It's a good place to start the show because it is really the first problem we have in healthcare. But there's a bunch of other myths, and let me run through kind of my top 10. We believe that we already have or are near to having cures for everything. That's another one. We believe that what's good for us as individuals is also good for the human species or is good for society. When it comes to healthcare, we seem to think that what we want is exactly the same thing as what we need. We either believe that the government is the only one that should provide care to us, or we believe the opposite, that the government should have no role whatsoever. Another myth is that we believe that America can afford it, whatever it happens to be. And if America can afford it, well, then I can afford it because I should be getting this care for free because now it's an entitlement, or we believe it is. We believe that employer-sponsored insurance has been a really good thing. We believe copays and deductibles have helped lower costs and reduce consumption. And, there's many, many other things that we believe that are myths as well. And one of the big ones you just brought up is we believe American healthcare costs too much. If you calculate it based on the numbers that exist, we do cost too much. But as you and I know, those numbers don't really add up.
No, they don't. And we're going to go into that in detail because I think what people are hearing and what reality is totally different. And they don't understand what is going on in terms of what the numbers are being thrown out there and what's actually occurring in the payment and the economics behind this. It's grossly exaggerated. And we'll talk about the reasons for that. When I look at the people I've dealt with, I was just at a recent seminar with some pretty high-level executives at a major healthcare company, and we were sitting around talking over dinner, and they're aware of what we're doing and whatnot, and what our history's been. And this is a technology-driven company. This is a company that provides bigger, better, more technology. I won't regress to what that is, but you can imagine some of the most elaborate and expensive diagnostic they have to do with MRIs, CTs, the technology-driven segment of this environment. So the conversation was around we provide more technology, we therefore have more connected care, we are providing at a higher cost more technology to the physicians, to society, hospitals, so they can have the highest grade of technology so they can do the best healthcare possible. So we are improving healthcare and we are improving the lives of individuals. And my response back was, well, if that's the case, and we're spending all this money on technology, we're adding more things into the system that we can continue to drive demand, because the more supply we put into the system, the more it drives demand. This is not the same thing as you typically see in the typical capitalistic supply chain process, and we'll go into that. The more we add in supply, the more demand we get. And the rhetorical question was, if we are doing all this and supplying all this high technology, then tell me why the mortality rate has gone down 2 points in the last 5 years.
And what was their response?
They didn't believe me until I showed them the data. And I think the response is dumbfounded, and they point to many other factors. And there are many other factors. There's lifestyle, there's, the myth around population health, there's the fact that we think by connected technology and IT, we're going to solve all the problems in the world. So I think they're believing their own bullshit, to be honest with you.
Well, there's a lot of that going on, and you and I talk a lot about the issues like this. I mean, number one is we have, in large part, extended our lifespan from when my grandfather was born in 1872. When he was born, it was around 45 years old was the average lifespan, and today we're just shy of 80 years old. But we also think going out and getting care itself is a healthy thing to do, right? We're getting health care, so it should be safe and easy for us to do. And, we're going to talk in an upcoming show about the stats around this. But getting health care, just going to get health care, is one of the most dangerous things we do in our lives. Largely so, and it's actually become more dangerous since when I wrote the book. When I wrote the book, as you know, Around 250, 260 people a year out of 100,000 people die getting health care. And in 2013, the update on that data is it's now close to 460 people are dying out of 100,000. So it's actually become more risky since the advent of the last change in our healthcare system. And when you look across the system as a whole, part of the reason is we believe it's effective. And as we will be laying out soon, we know it's not as effective as we think it is. We know that medicine is still much more art than it is science. And it will be that way in a long time. And then I think the last point you brought up is, look, technology, we believe, always is going to make life easier, better, and more efficient for us. But I've been in the tech game going back to the release of the personal computer in the late 70s. And I can tell you from personal experience, both selling them and being in the manufacturing side and franchising and installation and delivery and software and things of this thing, computers have never really developed the efficiency. We haven't saved any jobs and haven't saved a lot of money from technology. There is a role for technology in healthcare, but it is not the cure-all or the be-all for everything. And frankly, bigger and more expensive is not necessarily bringing us better care, because while the technology may tell us more and more information, the doctors don't have a basis to apply that information into a diagnosis with a scientific best practice that allows them to improve the quality of their diagnostics. So just this spend in technology has massively increased the cost of care on one side. It's one of the contributors. And on the other, the benefit to the patient has been very dubious for quite a while. Technology is seen as this new God. It's something that is going to save us. And this technology God is not doing a very good thing for us at this point.
Yeah, and I don't want the audience to think that this technology has not had a benefit. I've seen some tremendous amount of positives come from such things as IMRT, IGRT for the treatment of cancer. We can focus in on the cancer tumor and not evade the margins and break down good tissue. That's really important. On the MRI side, we can do some incredible things in soft tissue. We have a word in the provider market. Everyone comes into the hospital through the CT scanner, and everyone leaves through the CT scanner. That's very true. The CT has eliminated a tremendous amount of pretty unfavorable type of other exams that were really difficult. And so I don't want to allude to the fact that technology hasn't helped us. But at the same time, that is not what I think we're going to talk about here. We're going to talk about other things that I think elude our ability to get a grasp around the cost associated with our healthcare and what this actually means. Again, healthcare is all about trust. This is the biggest trust equation in the world. It has to do with whatever you trust your doctor to do, because you don't know. And the other problem within healthcare is a lack of transparency. There is no transparency. If you go in to get your car repaired, are you going to spend anything they tell you it's going to take without knowing ahead of time what's wrong? You wouldn't do that. You wouldn't do that without getting estimates or costs and anything like that. That does not exist in healthcare. There's no transparency. The only transparency you get is after your treatment, you get an EOB, explanation of benefits. You have no idea until you get that exactly what you're paying for and how much they're charging. And that's a whole other topic around what they're charging. So I don't want to dismiss this. The other thing I want to bring up is we were under the impression that electronic medical records, that's all we heard about. This is going to solve all the problems in the world. You're going to take it, they're going to do something with it, you're going to transport it, it's going to be available across what commonly referred as IDNs, integrated networks. Now, that's as far from the truth as possible. So we've spent billions of dollars in electronic medical records. It's been part of the entire program around the government's funding of different programs to enable some sort of a subsidy or whatever. There's a meaningful use, those types of things. But when I see electronic medical records, it's a whole lot of input with a tremendous amount of data that doesn't aggregate the data to let you know what the data is telling you about what needs to be done for an individual healthcare episode. That's been my experience. I don't know where you stand on this, but we spent billions of dollars collecting data, and we're data rich and we're knowledge poor. And I just kind of get your feel on that.
It's like the idea behind the technology itself is we are collecting lots and lots of data, and we now have companies like IBM with Watson that are going to somehow take all this data and use it to help us get a better healthcare system. And I think in the long run they can, but the problem is that much of the data that we're collecting is redundant in one form or another. And the problem with EMRs today is doctors are now getting overwhelmed with lots and lots and lots and lots and lots of data. And the problem is they're used to diagnosing diseases where they really don't know much about the disease. If you look across the history, and even if you come up today, in fact, I've got a book that's called Demand Better by Dr. Sanjay Kumar, which is one of the books we should add to our source. And this book will tell you that 80% of the things doctors do today, 80% of their protocols, don't have a basis in best practice science. In other words, there's no real underlying science. It's just, this is the way we've done it for years. It tends to work. Well, it tends to work not because it did much, as we'll talk about in the future episode. Much of our healthcare is reliant on the fact that our body's pretty good at repairing itself. After thousands of years of evolution, we've got pretty good at fighting off most of the things that attack us. Although for the past 50 to 70 to 100 years, we haven't really been in evolution. We'll talk about that in another episode as well. But we're pretty good at solving these things. So when you look across a doctor, you look across what they do, you realize that the chances of them curing us are not high. The chances of them helping us overcome the disease by what they're doing are not high. They're not zero, but they're not 100%. And as a result of that, we think now that somehow throwing more money, getting more care is going to make us healthier as a people. And in every single study, in every single thing, from the economics of it to the outcomes of care, it all indicates that more care is often not better for us. It's not better economically. It's not better in our own health-wise. And there's a lot of reasons for that. One of the reasons for that is hospital-acquired infections. And hospital-acquired infections are rising because we're not evolving as a species. We have antibiotics that keep us alive as children so we can reproduce and carry the gene for susceptibility. So there's all these things that we do over and over again in our lives, and we've built into a healthcare system that bring us back to the same fundamental point, that we can't fix what we have today until we start to rethink how we're going to solve the problem of the needs of those four legs of the stool. And once we solve those problems, then we can start to define how we're going to bring this together. There is a role for technology. There is a role for better improved diagnostics. There is a role for better information. But the last point about that information issue is the information we gather today around a patient is within the institution. We talk about patient-centered care, but it's only patient-centered within the institution. So if you're at Kaiser, the doctors in Kaiser, yeah, they have a patient-centered way to look at you. But when you step out of the network and you go to a doctor that's either independent or might be with Aetna or Sutter or someone that's not Kaiser, Kaiser's system doesn't communicate with them. They're no longer, you're not in the center, you're out of the network. So we really have to get to the point where patient-centered systems are truly centered on the patient, not just the information, but all transactions, so that when the patient is in the center, we have a virtual care group around them. And it makes no difference what network the doctor belongs to. It should make no difference whether they're independent, and it frankly should make no difference what kind of care they're bringing to the table. It should all be managed and coordinated through a center point of administration that fully coordinates all care and benefits across all sources. And that's the kind of system that will get us to where we have efficiency and effectiveness and improved outcomes, and will allow us to have people that can get the care they need when they need it, including an effective, efficient, cost-efficient safety net, and still provide the ability for them to get the care they want and find a way to pay for that care without having everybody else pay for all the things we want and don't need.
Well, this is amazing because this is our first podcast, and you're a great straight man because it leads into my next question.
You think we scripted it?
Yeah. Like we really worked that really hard, didn't we?
That 4 hours that we had before this didn't have anything to do with that, right?
Yeah, I think we've just been doing this so long. And to your point, I want to go one more place with this before we wrap this up. There's a lot here, and I think there's going to be people scratching their head. You know, what's this about? What does it mean? Why is this as bad as we? It's not bad. It's just the facts. And I think people understand. But here's what I want to leave it with. And I want people to understand this. This system we're in, you described just a minute ago what it's like to be within a Kaiser system, what it's like to be within an IDN. And believe me, there's nothing integrated about it in most cases. I've seen the best of it. I've seen people do it better than others. And until I went to Cancer Treatment Centers of America, I never saw a real integrated system. But that group operates in a whole different set of principles. So I'm going to put that on the sidebar for a minute.
And they're one of the first really almost retail care facilities in the U.S.
They are strictly retail, and we'll get into that later. So I don't want to. I got a whole different program on that. But let's talk about the current situation. And I think people need to understand what this means, because you just described something that puts us in the crossover as patients. And that's this hostile, predatory economic care climate. And what I mean by that, and I want you to elaborate on it, and we'll get into detail later when we get into the history. Hospital versus hospital. Doctor versus hospital. Doctor versus doctor. Insurer versus insured. Insurers versus providers. Drug maker versus drug maker. Medical manufacturing, high-tech medical manufacturing versus high-tech medical manufacturing, medical device business. Specialty hospitals versus community hospitals versus hospitals that are for-profit versus not-for-profit, faith-based hospitals versus the rest of the world, IDNs that continue to want to grow because they think that getting bigger is better. And all of this has one thing that's not included in that discussion, and that is us, the patient. So we're going to go into each one of these in detail in later episodes, but get high level. What are we talking about here? Because you were the first person that made me understand just how hostile this is. And then when I went back and looked at my payer mix, and I went back and looked at the fights I was fighting every day with denials, this doctor mad at me about this hospital wanting to get a better deal on this. It is a absolute predatory, hostile economic environment. And elaborate a little bit on that and how that affects the patient.
Well, first and foremost is that when you look across the system, you've got a lot of people playing in it, and they all are walking around, and there's the patient out there. And I have this nice little chart that you put together for a presentation, and you've got all these people all working around, and the patient is actually off to the side. He's not in the middle. And many people come into healthcare and they think they're going to solve for it, and they come out of the idea of supply chain. In fact, we've got a couple of new players coming into the marketplace announced in the past 2 weeks. I won't talk too much about them, other than one was going to originally be in the bookstore business and wasn't going to have any bricks and mortar, and now they're looking for another 1 million square foot facility, and they don't sell as many books anymore as they used to, and they're not all that profitable. But somehow they believe that they're going to come in and change technology, use technology to change healthcare. Well, the problem with all that is they come at it from a supply chain view. That, if I'm making blue jeans and I've got a guy down growing the plant that gives me indigo dye, and then I have a person on the other end buying a pair of blue jeans, that person's dollars that they're spending for the jeans filters all the way down that supply chain to the guy making the indigo. And somehow responsibility for the quality of the indigo goes all the way up to the chain. And if the indigo is bad, the guy doesn't buy the product. The problem in healthcare is we don't have a healthcare system. None at all. And there is no supply chain. The patient is not in the middle. So doctors and hospitals and insurers compete with each other and scrape and pull at each other. That's where their margin comes from. That's where their ability to cover their costs comes from and make a little money and go home and support their family. And when HMOs hit, we changed the nature of how this nasty little mess down here works. And we started to try to suppress the role of care as if there is a supply chain. And the reality is there's not. So the problem today is, as soon as you bring a payer into the loop, other than the patient, that you bring an insurer in, the patient is no longer in the picture. In fact, when the patient tries to get their information, their healthcare information, they have to go through a process, and people don't want to give it to them because the system isn't geared around them having any role. And so patients are lost in this system. If they can talk to anybody, most of the people in the system don't really want to talk to them. And when we do talk to them, back to this issue of the bill, we get a bill and we get a statement of benefits. And we look at this thing, an explanation of benefits, and we look at it and we see all these numbers all over, and we see something over here about payment and something over there about invoice price. And in the insurance world, we really don't know what the hospital or the doctor was actually paid. And if we don't have them in the loop and we go and we get a bunch of stitches in our face because we fell and we didn't have insurance, and we get a bill for $500 and we say $500 stitches are too expensive, when in reality, they're not $500 stitches unless you're stupid enough to pay that bill, because the doctor is not getting paid. The hospital is not getting paid $500 by anybody else. They're getting paid around 22 cents on the dollar. And the average person looking at an EOB or whatever else out there to look at this, they can look at all the numbers and can't gin it down to what's being paid. That's number one. And even if you did get the right numbers and added them up, and you said that the aggregate number, we're supposed to spend $3.9 trillion this year in healthcare. $3.9 trillion across all healthcare. That is the estimate of what we're going to spend. And I can tell you right now, we aren't spending $3.9 trillion. That number is wrong, and it's wrong by a lot. And part of it is, even though we may have written checks for a lot of money, for instance, with drug companies, they are under federal mandate to send back rebates to any federal program, including Medicare, Medicaid, TRICARE, and these other federal programs. And those rebates are coming after the drug has been bought. So in the state of, well, I won't mention the state, but in one state that I'm very familiar with, they spent about $500 million a few years ago on HIV and AIDS medications for people under the Ryan White Care Act. So they actually wrote checks for $500 million. But at the end of the day, they didn't spend $500 million because they received a rebate back from the federal government that came from the drug manufacturers themselves that put almost 50% back into the system. They spent $500 million and they got a reimbursement for $248 million. So in the end, not only didn't spend $500 million for the care, we spent significantly less, but we did it in the form of a rebate that doesn't show up as a tax, but that's what it is. And that rebate gets assessed after the year. So every year now, that rebate goes up and up and up. And in one episode, we really should talk about this, because if you take a drug today at $5 and I run it out the actuarial life of Medicare, which is 75 years, if I never changed the price and I just did it off of that increase every year due to the rebate, in 75 years, I got a $12,000 drug. And that's not just associated with a drug in healthcare. That covers a lot of other things in healthcare today. So the problem with all this is the patient is not in the loop. He doesn't have any control over his own healthcare. And when he goes to get it, it's really difficult for anyone to help him unless they are a doctor or a nurse that's in the system. And the problem there is, if we fix something for the doctor and the nurse, we break it for the hospital. If we fix it for the hospital, we break it for the insurer, because, again, there's no system here.
Yeah, I mean, there's a lot there. I think that we have multiple episodes on this. I think when people come to me and told me about the price, they don't understand. When we were in the imaging business, we'd bill $5,600 for a PET CT. Our average reimbursement, all across the board, from Medicare to our payers, was $1,500. So people don't understand the difference between list price that's being thrown out there is what we're spending, which is not, I think, exactly what you mentioned, versus what I'm going to call net price. It's a huge difference. You and I looked yesterday at a very large IDN whose patient net revenue was in the billions of dollars. But when you look at the percent discount, it was 72.3%. They're getting 18 cents to the dollar, correct?
Yes, which is less than the 22 it was 3 or 4 years ago. And hospitals no one can operate on 18% margin. So they have to find a way to cost shift it to other things, or they have to bury it in some way and raise money. And it's become a nightmare for hospital administrators to try to keep their doors open. There are some places that are making some money. There are some places that make a lot of money. But most of those places are places that have moved away from a traditional care model, a traditional insured care model, and have become more and more a retail presence, like Cancer Centers of America is one, and others. So we are sitting in the middle of the beginning of change. The change is going to be evolving along the lines of what we're going to be talking about in terms of the final system we can build here. But the difference is, if we do it in a controlled manner and actually build the system, we'll gain the efficiencies, not the quagmire we have. That's one. And two is we can build in an innate method of checks and balances so we can provide full coordination of care and benefits all through one point of administration to lower the cost of care probably as much as 40%, free up doctors to do more quality care, and improve the outcomes for America and give people access to the care they want as well. So I think we can do this. I know you believe we can do it. And over the next few weeks, months, we'll be getting to that point step by step.
To that point, by the way, enjoy the dogs wrestling in the background on the video. It's hilarious. So I think at this point, let's wrap up this thing. I think the point that we want to bring out here, based upon this last discussion, that the patients they're really in the crossfire. We're in the crossfire of hospital versus hospital, doctor versus doctor, insured versus insured, providers and whatnot. And we're going to go into that in a lot of detail going forward. So I'd like to wrap it up here and then introduce us to the next series. And we're going to take it back now. We're going to go back to where we began, and we're going to take it in segments and how we got here. Because I think that's critical for people to understand, at least for me to understand, and give us a grounding in this, because I think I'm a big history buff, you know that. I thoroughly enjoyed the book, and I think it brings a whole new light to what giving people some information as to just exactly what's going on and why we got here. So our next episode is entitled From the Mayflower to Medical Mayhem. Actually, one of the best taglines I've ever heard. I told you that when I actually read it to begin with. So I thought we'd start with 1492 to 1776, Health in a New World, 1777 to 1849, Hospitals and Physicians, Never the Twain Shall Meet, and 1850 to 1899, Medicine Becomes an Industry. So that's what I'd like to leave as our next episode. And I want to get your final thoughts, and I appreciate the time today.
Well, Tim, I'm glad that you and I are on this journey together. You and I have spent the last number of years talking about healthcare and talking to people about healthcare and trying to figure out how to make some changes in America happen. And I think that we finally found a way to do it. We've gotten good feedback from the few test podcasts we sent out for people to give us some idea what they liked and didn't like. And we're moving forward from here. I would like to say also that there is another form of podcast that will be coming out under HealthReform 2.0. It is called Healthy Bites. And what Healthy Bites are really short 3 to 5 minute discussions that Tim and I will have about a topical subject, and use that subject to kind of bring us to why we are where we are today, what the historical reference is that's causing that problem, and also use that to illustrate, again, how we can take it forward. But those are going to be a short form thing. They will always be free and available all over the place. And again, you can get our information on iTunes. You can podcast available in Google Play, YouTube, Spotify, and we have a website which is healthreform2.0.org. It's on the screen. That's HealthReform, the number 2, the dot is spelled out DOT, and 0.org. So go there and you can find access to the podcast and more information. And I think that this is going to be a lot of fun, and you and I are finally going to be able to get the people out there to understand where we are, why we're here, and what we can do to improve healthcare in America.
Absolutely. It's a pleasure to be here. I hope people enjoy the program, and we're looking forward to the next one.
All right. Thanks a lot. Make sure, everybody, you hit the subscribe button, and we will look forward to seeing you very soon. Thanks again.
Thank you.